invited two docs from Maine Medical Center to join us this evening. And first one I'd like to introduce you to is Kelley Shultz, who is a pediatrician from Manchester, actually Manchester, New Hampshire. Sorry about that.
Not a problem.
Okay, and with a varied career that included primary care and pediatric hospital medicine. And her particular area of interest is patient safety. And what a big issue that is today. I mean, I think about all the places where we have gone in recent years on our medical mission. And one of the outstanding challenges is the safety of patients, the safety in the operating room, the safety all over the place is just incredible. And we are so lucky to live here in this country and to have a healthcare system that is incredible to take care of us all. And she's volunteered for the Paul Carlson Partnership and its work that's being done in the Democratic Republic of Congo. And she's been doing that for 3 years. Joining with us is our other speaker, Gunnoe, who is a retired pediatrician from Maine Medical Center. And he's also volunteered with the Paul Carlson Partnership in the Democratic Republic of Congo for the past 13 years. And Eric and I have known each other working at Maine Medical Center, passing each other in the hallway. And I remember you stopping me one day at an elevator saying, you know, you're doing really good work here. You're really collecting a lot of stuff. And at the time, Eric, I had no clue how much stuff we really had. And if you walk around these warehouses now and you see this volume that's coming in, we bring in 12 to 20 pallets a week into this distribution center, let alone the other places where things are arriving at our other warehouses. And so he's very happy to have his good friend Kelley here, who's been involved with him in this challenging work. So we want to welcome both of you here this evening, and I'll turn it over to you. Thank you very much. Yeah, we're going to share the screen. Do I do that? No. No. Down in the bottom. Even though we've all been doing Zoom for 2 years, you'd think we know how to do it, but there are always challenges.
It takes a minute for it to.
I can get my grandchildren to help me.
Absolutely.
Mike Kirchie just said he could get his grandchildren. Here we go.
Great. You can move that up.
Okay, can you guys hear me or am I?
You can admit one more person.
Where?
Admit.
Am I on? Can they hear us or am I on mute?
Can they hear her?
Can someone confirm?
You're on mute, Kelley. We can just hear you through
the
Partners for World Health.
That's what you want to be. You're good.
So the only place you can, okay, so can everybody hear us?
Yes.
Good.
That's good.
Should we move closer to that?
Yeah, you can move down.
We'll slide ourselves down a little bit here. We're gonna play musical chairs. When the music stops, everybody sit down.
Hey, everybody. Thanks for caring about the rest of the world. It's going to be a nice little break. We're not talking about politics tonight.
Can everybody hear him?
Yes.
Yes.
Yes, yes.
So we work with an organization called the Paul Carlson Partnership. It's a Christian NGO based in Chicago. If you look at their website, it looks like they got 1 million employees, but that's the way websites make everything look. There are 4 employees and about 10 volunteers, and we work specifically in the Northwest Democratic Republic of Congo. This was founded by a surgeon's family. This surgeon in the early 60s was killed by Congolese rebels in the area in which we work. And it's existed since that time. We got revitalized in early 2000. I got involved about 2009. And I've been going to the Congo every year for the past 13 years. Kelley joined, my good friend Kelley joined about 3 years ago. She's made 2 trips to help teach. We're pediatricians, so that's what we teach, but there are plenty of other people doing other things also. There is a very large sister church, sister denomination called the CEUM, or the Covenant Church of the Congo. Our denomination in the US, the Evangelical Covenant denomination, has 130,000 members. They have 800,000 members. They support agricultural projects, build bridges, improve water, and then we do the medical work. And decidedly, we don't do any hands-on work ourselves. We believe that the best way to amplify what we're doing is to train the trainer. So there's a very limited number of trainers within this healthcare system. In pediatrics, there are 3 master trainers. And so whatever we go over to teach, they're in the first course. And then they take it the day after they graduate from our course, they teach the next group of people while we're still there. So if they have questions, they can ask them. We did that first train the trainer trip for helping babies breathe. You may know something about it because Ann actually taught me helping babies breathe many years ago, a newborn resuscitation course. So this is the area that we work in, circled up there. It's on the border with the Central African Republic to the north, and to the west is the Republic of Congo. These are the 3 poorest provinces in the Congo. They're poor because there's no infrastructure there. There are 0 paved roads. There now is some internet, which has really facilitated the work that we're doing there. And there is a bank that has finally landed in the area. So that means that in order to pay the hospital employees 10 years ago, a pickup truck went around with bags of cash to pay people, and you can imagine the problems that caused. So there are 26 provinces in the Congo. We only work with 3, and we only work with 4 of the health zones within that country, in that area. You know, it looks like a small area to us, but if you think of the Congo, if you laid the Congo on a map of the US, it would span from Boston to Houston, east to west. And then the area that we work in is the size of Connecticut with no paved roads. So it's all bush plain. And if you have a lot of courage, you might take a riverboat up there, but this is something I want to do that people have warned me against the danger of that. So there are 4 hospitals in the area that we work in. There are 120 clinics, 36 of which are independent. That probably means very little to you. But really what it means is these are clinics that for political reasons, the denomination felt compelled to add on, i.e. when they're trying to work with a specific tribe, that tribe wants a clinic too. But they fall outside of the purview of the Congolese government and outside the purview of the health zones. So that makes them orphans, so to speak. There are about 200 nurses in the system and 19 doctors. So it's a finite number of people that we can train. When we go over every 6 months, a team is going over there. Individually, I just go once a year, as does Kelley, but it takes about 6 months to disseminate the training that we provide so that they're ready when the next team arrives to start the next cycle of whatever training that is. There are 1.2 million people and about 14,000 live births per year. How long do you stay there? We try to make it exactly 2 weeks because we found that if you're trying to get a doctor out of the call schedule here in the US, you can do it for 14 days, but if you ask for 15 days, it makes people mad. And we try to straddle it over months because it's easier to accommodate a schedule rather than 2 weeks within October. It's much easier to do the end of September and the beginning of October. Just a mission statement like everybody else's. I'm not a huge fan of mission statements. This depicts all the work that the Paul Carlson Partnership does. I'm not going to get into the detail of this other than to point out that we do provide a stipend for pharmaceutical purchases. We do provide a stipend to subsidize salaries, which are terribly low over there, and then we do the training. We do quite a bit of infrastructure work and trying to improve the water, which means either digging a well or putting a masonry box around the outlet of a spring to keep the hogs out of there, basically.
Hmm.
By the way, you're welcome to ask questions whenever you want to, you guys. So here's the train the trainer model. I bet you're familiar with it. It works very well. We teach 2 iterations of the course while we're there. We do the first one. Master trainers are in that first course. We limit the size because we use low-tech simulation devices. You probably know that from your contact with Aunt Carol. But we use similar low-tech devices there. And those courses really can only handle about 12 students. So 2 students per simulation device working in pairs. And then once we teach the course, there's a written test, there's 2 practical tests, and then they get a certificate. We forgot that the first time there, but getting a certificate is a huge, huge deal. I don't know if that's true. in
Same
the
thing, exactly the same.
Oh my gosh.
Everywhere. For any educational.
Yeah,
Either a certificate of attendance, certificate of professional development, or some kind of certification. That you're trying to
yeah. We had an artist design our latest certificate, and it's been a rousing success.
Yeah.
Well worth the money to do
It
that.
helps people keep their jobs, basically. Yeah.
And they've accomplished something, and they feel good that they've been successful at it based on the standards that we have here.
And if you go into anybody's house, it's in the place of pride in the house. It's very touching. So we like to emphasize that we're there to train nurses. And the reason we say that is, at least for the first 10 years of my involvement, if you trained a doc really well, they would go somewhere else. And where they wanted to go was Kinshasa. And ultimately where they wanted to go was Brussels or the United States. So the great thing about nurses is there are lots of women in that demographic. Women take care of the people around them and they stay where they are. So if you really want to make a difference in a system in the Congo, and you train the mothers to do things, and you can be sure that they'll stay around. So the master trainers then teach the next course. We might be there to tweak, but there's not a whole lot that we have to do. And I laugh. And when I told Kelley about this, I said, the second half of our visit there is just going to feature us sitting on plastic Walmart chairs, watching the Congolese do what we taught them very well.
Do you have non-physician clinicians like they do in other countries?
So we struggled with that, Mike, because there are traditional birth attendants in the Congo. And I advocated that we might as well teach them how to use an ambu bag to resuscitate those kids that were inevitably going to be born there. That decision got taken out of our hands by the Congolese government when they outlawed them. But we're fine. For example, nutritionists are often not either nurses or physicians. And those are the people who do most of the teaching around malnutrition in the Congo.
In East Africa, they have non-physician clinicians. And the advantage is you can train them, it's cheaper, and they're not obsolete because they really can't use their training other than their local community or district.
So that'd be the equivalent of a nurse practitioner or PA.
Right, except they're trained as a master in that to do surgery, such as cesarean section.
Could folks hear what Mike's question was and what the discussion is about? I can only see about 3 of you on the screen. You're talking about non-physician or non-clinicians?
Non-physician clinicians.
Yeah. So nurses are really they're the most important component of the system there. And I'm not just saying it because I'm sitting amongst nurses here. They can do surgery and do surgery, but the Congolese government is conflicted about it. There are plenty of people who are trained plenty of nurses who are trained to do appendectomies and C-sections and hernia repairs, but right now they're not able to do that, or they're not legally able to do that. So this is a slide to thank you guys for what you do. This is all the stuff that we have bought from you. And I can tell you that the Congolese and the Americans in our organization are delighted. I quote the price that you guys used to charge us for a bag of stuff, and it was 50 cents a pound. And I loved that number so much. You're up to $2 a pound, which is remarkable.
I think it's for
It's three?
inflation. You know?
Ah. 50 cents was such a beautiful
7%,
number.
Inflation. Yeah.
Anyway, the point is, you guys, what you're doing really makes a difference. I tell a story to the Congolese, right? The first time I went to teach, I had collected a bunch of bamboo bags, resuscitation bags from my PICU, and I bought some from here. And they asked me where I got the stuff, and I said, "You're not going to believe this, but all this stuff was on its way to the garbage dump." And the nurse, that one of the nurses said, "God's going to be very angry with America for the way that they waste equipment." And it is absolutely true. I'm ashamed of what we do. But if it weren't for our wastefulness, this organization would not exist. So here's how we chose what to address in an overwhelming situation. What are the top 5 killers in the Congo? These are not unique to the Democratic Republic of Congo. It's respiratory disease, diarrhea, and dehydration. Newborn-related deaths, either prematurity or birth asphyxia or neonatal sepsis, malnutrition, and malaria. So we started on the easy one. The easy one was neonatal mortality. You guys probably know this from your association with Ann, that 10% of babies born everywhere in the world don't take their first breath. But it's very easy to restart 90% of those kids with just a few breaths with a positive pressure ventilation device. It doesn't require oxygen, doesn't require anything else really other than drying the baby off and doing clean cord care, and then the positive pressure ventilation. So those devices now, I think you guys are charging $5 a piece for them. You are.
Yeah,
I
around
just bought
7% inflation.
The price goes up every minute. So those devices are intended for single patient use and would otherwise have been discarded in the US. They're in every patient's room in a NICU or a PICU, and they get thrown out whether they're used or not. But they have a life that extends for years in the Democratic Republic of Congo. The only thing we have to replace is the face mask. And I'm very proud of all the Main Med Center and bamboo bags over there in the Democratic Republic of Congo. It's a very poor country. You can see some of the data there. In terms of medical spending, the government spends an average of 58 cents per patient per year on their population. It's a very dangerous place to be a pregnant woman also. I'll show you some of the data on the maternal statistics. So these are the courses we've taught over the past 10 years, with the exception malnutrition is not listed. There's a very active maternal care unit, equally active, really. You can see the courses they have taught. All of these courses that you see on the screen were sponsored by the World Health Organization, an American organization like the American College of Obstetrics and Gynecology or the American Academy of Pediatrics. And then thanks to Lairdall's very generous support, developing the printed material and the low-tech simulation devices is actually pulled off. And Kelley, one of these is actually a video, right? Or is
Yeah,
that
next.
on the next screen?
Hit it.
All right, yeah. This is the first master trainer we had for pediatrics. There's a translation here. Her name is Sister Astrid. Turn the volume up.
na formation epidemiologique ezalaka soki théorie na pratique ezalaka facile comme oza comprendre te selon pratique ndenge tosali tosauve bana ebele chaque mois 15 et 20 bana oyo tokozoreya bango bazobika ntango mosusu oyo ezalaka soki oreanire mwana mpe mwana biki epesaka pe biso mwa sai plus de 20 na niveau hôpital après médecin coordinateur abengaki apesaki nga nzela lisusu mpona koforme bainfirmier ya centre de santé d'ailleurs kokendela docteur libre torekomandaki ye te ezala mbala suka te mpona formation ezala continue toyebisa ye docteur te mpe tokoma na mokanda na yebi te soki mokanda lepesokasi
Can you guys hear us back?
Yes.
Okay.
Yes.
So we're gonna trade presenters here, but he's sitting right next to me. So if anybody's got any questions, so we're gonna start to talk a little bit about the tips that we've taken, just to give you a little bit of a feel for what it is. Eric's talked a little bit about helping babies breathe. Certainly in 2020, we all got stymied. Nobody went anywhere. So we sort of picked ourselves back up in 2021. As he said, Helping Babies Breathe was a course that was designed to try to take care of those kids that never took their first breath. But the other thing that happens to kids in an environment like this is that if they're born premature and don't have the innate ability to suck, there was nothing that these families could do for these kids, and they would die. So the course that we took over in 2021 was called Essential Care for the Small Baby, and was very specifically designed to try to take care of premature infants that couldn't feed themselves. So we concentrated on things that little teeny tiny babies struggle with: temperature regulation. We taught the healthcare providers to teach the mothers how to express breast milk. They had no idea how to do that. That was something that was not on their radar screen. If they didn't have a baby that survived, there was no reason to have milk. We taught them how to do some things like cup feeding, if they could try to present that instead of suckling at a breast. And then for kids that couldn't do any of that and were too small, we actually brought over and taught them how to place NG tubes, and then taught them how to decide what the appropriate feeding volume was for all the premature babies, so that they didn't just overfill their stomachs, which are teeny tiny. And then as the kids grew, taught them how to transition from what we were doing with NG tubes or cup feeding back to breastfeeding and get these kids to survive. As Eric said, the results have been stunning. This is a slide that shows you a little bit of the graphics. We talked about the maternal data as well. This is data from the last 5 years. You can see a pretty steady decline. 2021 had a little bit of an uptick, which apparently is kind of on its way back down again. But the remarkable side of this is that data has shown a 78% decline in the maternal mortality rate. As Eric said in one of the previous slides, prior to all of this work, the Democratic Republic of Congo, this little section of the world, shared the distinction with Somalia of being the worst place in the world to be a pregnant mom or a baby. So this is pretty impressive data. The bottom part of this shows the infant mortality data. And again, you see the pretty steady decline in the last 5 years, with a less than 7-day infant mortality rate being dropped by about 48% with all this work. So it's actually pretty cool. It's the kind of thing that keeps people like me coming back for more. And so it's fun to see that we're actually doing something that sustains itself and makes a huge difference to this population. In 2022, the pediatric resource group kind of switched its focus because we actually ran out of prepared courses for the neonatal side of this. There are still more maternal courses that they have been able to teach. And when we went back in 2022, they taught a course on the difficult delivery as well as obstructed labor. But as I said, we turned our attention to malnutrition. Malnutrition is a huge problem, accounting for just under 50% of the deaths in underdeveloped countries. That's both a primary and a secondary cause. As everybody can well imagine, poverty is certainly right up there on the list of things that predispose families and their kids to malnutrition. But what we noticed was that it was even more pronounced if there was a cofactor, if you will. So a mom that wasn't literate, a father that lost his job, migration to a different region, or some chronic illness, malaria, HIV, tuberculosis. In the little section of the world where we work in those 3 provinces in 2020, the data showed just under 4,000 kids between the ages of 6 months and 5 years with severe acute malnutrition. That's a huge number. About 15% of those kids are so sick that they have to be managed in a hospital setting. And in this particular part of the world, although the World Health Organization would like our mortality rate to be less than 5%, it's actually way up at about 18%. So we have a lot of work to do. And that's sort of what we set about trying to do. The curriculum that we created was done in combination with the Congolese providers, Eric and I, and the rest of the medical ambassadors on this side of the pond. And then the Congolese providers in their country helped us over about 10 months create a curriculum using the World Health Organization's little book here as the foundation, with the idea that what we were going to do was address the 3 major categories of malnutrition, which you see here. Sure, that's your cue, Eric. You can talk about that if you want to. These are the components of what the course was designed to take care of.
So a busy slide here, but it's really the guts of the course that we developed. There are 3 severities of kids with moderate acute malnutrition, and you figure that out based upon their arm circumference and the ratio of their weight with respect to their height. So skinny kids get screened positive on that. You can see the criteria for moderate acute malnutrition. By the way, moderate acute malnutrition can be classified that way as long as they do not have a complicating feature. I'm looking for the.
You can't do it.
All right, in the upper right-hand corner are the complications. Any one of those complications, no matter how the kid screens out from a height and weight circumference perspective, automatically puts the child into the complicated severe acute malnutrition category. Second category is severe acute malnutrition without complications, so even worse body measurements, but no complications. The great feature about both of those categories and the 85% that Kelley alluded to is that they can be taken care of at home with weekly visits to the clinic for heights, weights, arm circumference, screening for complications, screening for compliance, and then another 1-week supply of fortified peanut butter, which is known commercially as Plumpy Nut, which I think is the most important food in the world.
To get to their weekly.
Great question, Mike.
So Mike Kirchie asked an important question: how far do they have to travel? Let me just tell you what it was like before we started the system. They were doing this, but they had a stabilization center that required that even the moderate and uncomplicated severe acute malnourished kids had to come back to the stabilization center. Now the Congolese have wisely chosen to push that back out to the clinics. And so distance to clinics is not very long. So those kids are set. I'd say a maximum of 10 kilometers to get to the clinic. But to get from the clinic to the stabilization center, if you happen to be a severe acute malnutrition with complications, sometimes is upwards of 40 kilometers. It's life-threatening. And so the Congolese are currently debating whether clinic nurses should be allowed to place nasogastric feeding tubes and to just do all the refeeding there at the clinic. I don't know the right answer. We're still debating that as the system is forming up.
If they're well trained, they should be able to.
Yep, and there are plenty of nasogastric tubes to go around for the clinics. I favor them being allowed to treat these kids out in the clinic, because otherwise they're going to be parents who are just afraid or too poor to travel. So the sickest kids are cared for at a stabilization center. I think we have a photograph of the one that was just built in Karawa. Those are the kids that are not fed with fortified peanut butter, but they're fed by commercial medical grade formulas called F75 and F100. Very difficult part of those commercial grade products is the World Health Organization has chosen to license only one company in the world called Nutriset in France to make all of these products. And so a small system like ours is having to compete with the government of Ethiopia or Oxfam or USAID to get these kids these medical grade products. And it's made it a very laborious process to try to buy relatively small quantities of these items. I think we're back to Kelley now with some pictures.
Yeah, I get to do all the fun stuff with the pictures, which is great, right? So as Eric said, you know, the project was about 10 months in coming, and with the previous slide, that's the focus. We actually had just a little shout out to the medical illustrator. We had a medical illustrator that created the curriculum for us. It's we've got one floating around here on the table, the cover of which you had in the previous slide, and she did just a fabulous job of trying to capture the pictures that go along with trying to teach this course. So when we travel, we pretty much had the entire United States covered. Let me here, I'll show you. I'll see if I can show it to you. Just can you see it?
It's a flip chart.
It's a flip chart, and it just to be able to see some of the pictures that were drawn by the illustrator there, it's just stunning. She did a fabulous job of making this very real to the Congolese people. One of the things that we remember was when we had we wanted a picture of an IV pole, and she drew an American IV pole, you know, metal hooks, and Eric was like, no, we need to make that wood, and we need to make that more realistic, and she did a beautiful job of it. So
tell about her offer to draw faces.
So what she asked us was whether she wanted us to have the real faces, the eyes and all that kind of stuff, and whether we wanted her to try to match that to faces of the people that we had pictures of in the Congo. And we just decided, no, that would be probably too much. But she was delightful in her query of wanting to be as personal as she possibly could. So back to this picture. So the medical ambassadors pretty much have the United States covered. You see there, we travel from all sorts of places in the United States. We met up in Brussels after an international flight, and then we fly down to Kinshasa, which is the picture that you see here, the aerial that you see of Kinshasa. It is the capital of the Democratic Republic of Congo, with about 16 million people. And I swear to goodness, every time we show up, every single one of them is in the streets driving some type of motorized vehicle. It's just stunning to me that nobody is killed in this particular activity, at least while we're involved in it.
Talk about how we joked on Forest Avenue trying to get out here and rush out.
Oh yeah, absolutely. I felt just exactly as if I was in the Congo, trying to dodge all the people that wanted to be where I was. We laugh about the fact that if you're not yellow in your cab or your car's not yellow, it has to be dented. Otherwise, it just doesn't work. you see the picture of the motorcycles, that's her taxis. And the interesting side of that motorcycle is those two people sitting behind the driver, our chances are completely unrelated to that guy. And they're just sitting on this motorcycle like they haven't got a care in the world, darting in and out of this traffic, honking at people. And, you know, some of them are on their phones. They're not hanging on to each other. It was just amazing to me. And the other fun picture is this little robot that you see in the picture here. That was their attempt many years ago to try to help the traffic situation. And so they put these robots out that were supposed to have red and green and, you know, all sorts of flashing things to get people to go where they were supposed to go. Well, they didn't work, but they've just left them there. So now they've created a different version of a traffic problem in and of itself.
Can I make a comment?
Sure.
The traffic is so heavy in Kinshasa. I say that if you're born on the left side of the road, you can live out your natural number of years by living the rest of your life on the left side of the road. Because if you try to get to the right, you're going to die young. It's unbelievable.
It is absolutely unbelievable. And the drivers are great. Interestingly enough, I was actually not all that nervous watching, you know, sitting in the back of these cars with the drivers doing this. And they do not, if you've been in New York, you know what it means to own a horn, but it is nothing compared to Kinshasa and the traffic. So we usually spend the night, right? Oops, let's go back one. We usually spend the night in Kinshasa, and then we travel across the equator and across the Congo River, which is the deepest river in the world and the second longest river in Africa, spanning 9 different countries, in a plane like you see here that is flown by the Mission Aviation Fellowship Group to take us up to where we're working. We usually, they pile all of our equipment and all that kind of stuff in the back of that plane. We travel with 10 to 14, 50-pound crates of all of the goodies that we get from Partners in World Health. And we land on a grass runway to the welcome of almost the entire village, which you see ringing the runway, the airstrip on the left there. And in the middle, you see a welcoming line, a receiving line, like at a wedding, which is almost all of the hospital staff that want to just shake our hands and meet us. And usually, although, you know, we fly in on a Saturday, there's often a celebration either that afternoon or a church service the next morning, which you see on the right-hand side here, welcoming us into the community. It's a gorgeous community. It's part of a big rainforest. You see a couple of houses here. These are the leftover missionary houses where we stay. These are leftover from the days when there were hundreds of missionaries in this part of the country. So these are the places where we lay our head at night and eat our meals and those kinds of things. So we usually start our work on Monday morning. And as Eric said, the course is taught twice by us. The first time has the master trainers in the course. The woman in the center is one of the malnutrition master trainers. The gentleman in the forefront on the lower picture there is one of the physicians. And everything that you see on the table here is brought over by us. So the simulators, the printed literature, all of the things that are required to teach this course and then to take this course out into their communities and teach other people, we bring with us. The second course is then taught by the master trainers, and it's just a delight watching these folks work. When I started listening to Eric talk about this work 10 to 13 years ago as kind of a voyeur, because it wasn't right for me or my family to be involved in it personally, he used to tell me that I would never encounter students like this ever in anything that I ever did. And boy, he is absolutely right. And these master trainers take over like they own the place. They make the course markedly better. They know their colleagues, they know the language, which makes a huge difference. Eric and I and the other medical ambassadors have to work through translators, but these guys know their system and they add to the course as they teach it in a way that makes it much more relevant to their world. This is sort of a list of the.
One question.
Oh, sure. Sorry.
You hit the chat button.
I hit the chat button.
Oh, I'll do it.
Sure. I'll try to do that. Let's see if I can do it. Is
Yeah.
family planning taught and are contraceptives available?
She's looking at me. I don't know. To
Yeah.
be honest, that's a great question.
I don't
Kelly
think
and I
so.
have just had our noses buried in pediatric stuff for years. I don't know the answer. Great question nonetheless.
Yeah, it's a great question. When we were there this year, we got in on Saturday, and the following Sunday there was a big church service, and kids were being let me see if I can go. Yeah, kids were being dedicated, and the service from the pastor was actually pretty directed at the idea that you didn't have to get pregnant right away after you delivered. We were really impressed. We were not having the entire thing translated, but the translators that we were sitting with sort of leaned over and went, I think what he just said was, you probably shouldn't get pregnant right away again. And we all kind of went, really? So we don't know the answer to the question, but certainly it was a topic of conversation. So as Eric said, the components of the malnutrition course focus itself in these locations, in the village, at the clinics, and at the stabilization centers. And just looking at this slide that has a lot of words on it, you can see a couple of things if you kind of put together some of the things Eric and I have already talked about. So as kids get sicker through the continuum of moderate acute malnutrition to severe acute malnutrition without complications, and then the severe acute malnutrition with complications, they cannot stay in the village and be cared for at the clinics. And so they have to require a transport and a different location for their care. But it also is, as you can see, sort of a no-brainer that clearly if we can identify these kids earlier in the spectrum of their disease and keep them in the village and the health centers, we will theoretically have a markedly lower mortality rate and hopefully run the stabilization centers out of business. But we also save a lot of money. As you can see, the difference in what it costs to take care of a child at a stabilization center is just stunning. Right. There we go.
What we used to do in Haiti to find these children early, we would get up at 4 o'clock in the morning when it was still dark out before they went into the field. And under those circumstances, they were willing to bring their children in because it didn't affect their work schedule, which is a poverty situation.
Yeah.
One problem that we realized they were having is over there in identifying kids early is that parents are ashamed that they can't feed their kids, so they're ashamed to bring them to the clinic. So we hope that having a village council that's savvy to what malnutrition looks like will help with that problem up there.
And also having the ability to help provide them with the fortified peanut butter and the things that they need to be able to do something about it.
Smells funny.
Hoping that will bring them to the clinic to be evaluated. But Mike, it's a really good point. You just have to be creative and figure out how you're going to find these kids out there and get them into treatment.
But one of the things we recognize
That you used to like.
is malnutrition there.
It was the logs.
They look more like a Caucasian. And they're made.
Was that so the little swirly thing? It was down and it was getting really smoky. So
Yeah, that
I
was
looked it up.
Yeah.
It's hard to combat that.
Yeah, absolutely. So Eric talked about the new stabilization center that was built in Karawa. Here is the picture of it being built and then a picture of it as it's completed. We were fortunate enough to partner with a nonprofit organization here in Portland called the Protein Foundation, whose mission it is to help provide food to people that are starving. Their profits come from a group of businessmen from Connecticut that run an ice cream manufacturing plant in Traverse City, Michigan, and the profits of that organization go back into this foundation to then support their mission. We were very fortunate to be able to partner with them and get them to give us $40,000 to help get this built. And one of the folks from the Protein Foundation actually traveled with us to the Congo this time around. So we're hoping that partnership continues as we go forward. We were able to make rounds with the docs, and you see the stabilization center that was in the previous picture in living color here as it's working. They were standing outside on the left of the stabilization center with one of the docs who's reaching for one of the sicker kids. The set of twins that you see in the other picture are also part of our part of the folks in the stabilization center that are being treated. This is how we measure them. It is a very rudimentary sling scale. And you see the mom fist bumping, if you can tell in that picture, the nurse, because that little character gained weight, which was a huge thing. The picture in the center is the depiction of the mid-upper arm circumference measurement that Eric was talking about. That is a very important criteria of how we classify our malnutrition cases. And then on the right is the stadiometer that's doing standardized height for these kids. In the center of this picture, you see in the back an open air little pavilion sort of area. These are all around the hospital grounds because the families of folks that are hospitalized are responsible for making the food for the patients that are in the hospital. There is no room service. There is no dietary kitchen. There's none of that like we have in our hospitals. The stabilization center has a kitchen because, and that's what the forefront of that picture is where the formula is being made. The person on the left is one of our master trainers standing in the kitchen. And then on the right, you see a picture of the formula cooling from having been made. But it's just a stunning contrast to what we are used to in our hospitals, where a very large percentage of our complaints come from patients who think their food isn't warm enough or tasty enough. As Eric said, the roads are not paved. We were fortunate enough this time around to go to visit a couple of the clinics. The picture on the left is the road when it's dry, and the picture on the right is a picture of that same sort of road when it rains. That's not a stream bed. We are actually driving on the road, and the two clowns in the back of that pickup truck are Eric and I. That was last year. On a trip between Karawa and Gemina, but they literally flood like this and give almost nothing that we resemble as a road. This is a picture of one of the rural clinics that we went to visit from the outside, and this is the picture from the inside. The picture on the left is the birthing table and that's the size of that room where they deliver 28 to 30 babies a month. In the center is the net where the mosquito net and the mat where a patient might stay if they needed to be there for longer than just a short visit. And then the other two pictures are the treatment center on the right, and the room on the bottom is actually their pharmacy. Traveled to another clinic on a different kind of a road. I would actually call that a bike path, but we drove on that with a car. And then you see another picture of a clinic, which is a little different in terms of its modern sort of feel. This clinic had been rebuilt, but sitting out on the lawn, you see those brown things. Those are actually the mattresses, and they look like this when they get onto the beds in the clinic itself. Where they don't have, it's not a one-for-one phenomenon, because in the war, mattresses were a big thing, so they were stolen in some of the places. They have used cardboard and strapped it together to make a mattress. As Eric talked about, it's really all about the people. So for us, it's really about getting to know the Congolese providers and what it is that they need and how they think this system can be made better. In the center, you see 3 of the Congolese physicians with the 3 boxes of medicines that we brought over from Direct Relief. One of the picture above that is one of our master trainers, and the bottom is one of the physicians from another area of the region with a bunch of kids that are part of his malnutrition clinic. And then the picture of our family practitioner doing maternal care with a mannequin that actually is designed to deliver babies. Here's another one of our master trainers in the center. The guy in the yellow shirt is one of the physicians. Loved his shirt, so I had to take a picture of Winnie. And then the gentleman in the other corner is very important to our work. He's our translator. So just a wonderful guy that goes around and tries to help us communicate with these folks. The picture on the left is sort of a snapshot of what the hospital grounds look like. I took a picture of the COVID vaccination clinic, which is what you see in the other side of that picture, which happened to be on the day that we were making rounds and trying to sort of see a little bit of what the hospital setting had to offer. The picture on the left is what they would consider to be sort of their critical care triage room. This is the equivalent of what would be in one of our emergency rooms where the ambulances would come in with the multi-traumas. Everybody that I've shown this picture to says, well, you know, all the people are in the way of all the equipment that must be in that room if that's where they're resuscitating and trying to do that kind of emergency medicine. And my response is no, there is no equipment in that room. It is literally what you see. It's a bed. Behind the nurse on the left in the light blue shirt is just another counter that had a couple of trays of instruments that were waiting to be washed. So they really are very limited in the amount of equipment that they have to do the things that we sort of take for granted. The other picture is their X-ray machine, which works most of the time, I guess is a good way to say that. Sometimes it's missing a part and doesn't work, and then they just sort of have to muddle through.
There's also power. Do they use solar power?
Yeah, great question, Mike. They use solar power to run their generators and to be able to get enough to even do some internet, but it's very dependent upon weather and all sorts of things. Last year, when we were there in 2021, we struggled to have connection to do things like connect with our families via WhatsApp, because in July, before we arrived, there'd been a huge lightning storm that had burned the pharmacy building literally to the ground, and the solar panels got taken out as well. So it's really dependent upon weather and all sorts of things like that, and keeping the equipment up and running. Good question.
And refrigeration, which you need in a limited.
Yep.
It's frequently been used. Solar power doesn't have that much capacity, but a small refrigerator would satisfy that.
Yeah, and that's part of what our malnutrition curriculum equipment has included, is a small refrigerator to try to help deal with some of the storage of milk. It's a work in progress for sure. The gentleman on the left is a guy that helps take care of us. His name is Naselli, and I love this picture. He is on an open flame cooking fresh tortillas for us. The picture behind his shoulder there is the stove that they salvaged. It's a stove like what we might have had in our homes 20, 30, 40 years ago, but there's no cooking elements or anything that's electricity in it. He runs that stove completely on coal with charcoal, excuse me, with nothing other than his intuition to know when things like his wonderful sweet rolls are done. Again, the picture with the motorcycles in 2021 when we were there, we saw a picture of we saw a motorcycle with 7 people on it, but I couldn't get my camera out fast enough to actually take the picture. So I did find one with 5, which I thought was pretty impressive. This is a picture of the team that went over. The malnutrition team is there. You see the group of us that went over to try to deal with this. A couple of those people were actually in the Congo. One of them is a missionary, and then the niece of one of the missionaries that lives there. And then we also took a group over with us that was trying to do some legwork to try to establish a hypertension and diabetes curriculum, and you see that team. So that was just some of the fun pictures that went along with our trip. This is also a fun picture. This is actually from our 2021 trip. We passed this gentleman on the way in to give the denomination leadership a summation of what had happened while we were there. And an hour later, when we came back out, he was in exactly the same position, just sitting there talking to his friends. And so I just sort of took a picture of this. It's kind of my way of saying thank you very much for hanging in there with us over the course of this presentation. Eric and I are thrilled to have been able to do this. We appreciate the opportunity and the chance to come share this work with you, and are very, very grateful to all of the things that you guys here do for us to make this mission successful. Are there any other questions? We would be happy to take them.
How often do you send groups over there? You're there for 2 weeks, but how many similar groups over a year?
6 months. So Mike asked how often we send people over. The answer is every 6 months, and there's a specific reason for it, 2 of them, in fact. When we go, the Congolese think we have to have meat for every meal. They kill every animal, virtually, to feed us, and many of us, like me, are vegetarian. So it's a real strain for the system. There's not enough food to go around. And the second reason is it takes them 6 months to disseminate the new training that we do. So there's no sense in confounding the system by sending another group.
We're training all the same
So
people.
if there are 2 of you, then you only need 2 more 6 months later. I mean, how big is the surplus of docs that go over there to do this?
It's not big. The people who are serious about this and actually do the legwork are less than 10.
Because you need credibility, and so they need to see it frequently, know that you're not giving false information.
Eric's been there forever, and the guy that does the maternity work has been there for a very long time as well. And so but we're training all the same people. As Eric said, there's 200 nurses and 19 docs. So the more we go over with more material, we just overwhelm them. We have to kind of give them an opportunity to get used to what they're doing, to figure out how they're going to get that on the back of motorcycles out 2 and 3 hours from where we're teaching, and get that spread before we come back with new stuff.
Karen, we see your question. Nice, thanks. It's nice of you to attend. Karen's question is malaria next on the agenda focus. And our next focus is actually the biggest killer of kids, which is respiratory diseases, asthma, bronchiolitis, viral pneumonia, bacterial pneumonia, empyemas, and so forth. So it'll take us a while to get to malaria. Another reason why we put malaria on the back burner a little bit is the Congolese are much better than I am, for sure, and much more experienced at treating malaria. And then the other problem is, I think the only way to upgrade what they're doing with malaria treatment would be to get them some mannitol, but mannitol is quite prone to going to crystallizing. So we're not sure how to preserve it in that very harsh climate. Linda, if you don't ask a question, I'm going to tell the story about you grabbing the bull by the wrong end for years, which is still one of the funniest stories I've ever heard in a hospital.
Who are you talking about? To Linda Brady?
Yeah, is she on?
Is she, Linda Brady, are you still on?
Don't worry, you don't have to tell the story.
No, I don't think she
Did I hear my name?
did, Linda.
So here's what I said, Linda, if you don't ask, I'm going to tell the story about you chronically grabbing the bull by the wrong end for years.
What? I don't even remember.
I'll be happy to tell that story to everybody on this call if you want.
Maybe I better say no.
Linda, you're a wise lady.
Yeah.
Uh-huh.
You've known Eric a long time.
Uh-huh. I sure have.
Yep.
And it's been an honor. Oh my God. Geez, you caught me. I thought I heard my name.
You were back there smoking a cigarette probably in the office.
Yeah, right. No, I just got home. I even listened to you in the car.
Wow, we're impressed. That's above and beyond the Call of Duty.
Exactly.
Thank you.
Because one day I'm going to be with you guys.
That's right, Linda. We'd love to have you.
Love to have you.
That'd be
For
great.
sure. So, you
I'm
know,
rusty, but I'm trainable.
Bring Janice with you.
I think that given the situation today that's happening in Somalia with malnutrition, and I read a report yesterday about 5 million children under the ages of 5 are considered severely malnourished now in Somalia. They have a horrible situation going on. And I'm very interested to learn about this organization in Portland, Maine, that you mentioned. What was the name of it again?
The Protein Foundation.
The Protein Foundation. I'm sure you wrote it down. because we have been talking about how could we, knowing full right that Somalia needs medical supplies as well as nutritional supplies, given these 5 million children. So it's incredible what's happening in so many parts of the world, and we are so lucky to be on this side of the ocean.
You know, an even more incredible feature of that is you never hear about it.
Right. That's right.
We have no bandwidth.
Yes. That's correct.
Starving kids.
No, we don't. And we never hear about what's been going on in Ethiopia for the last couple of years.
Emily Leandro, the kid.
And
He was,
this is something that we've been working with actually in Ethiopia, because we've had a container that's been on hold now for 8 months waiting to be shipped because of the challenges with the civil unrest and all of these people being killed between the government and the rebels and the hospitals and being destroyed. And within the last 2 weeks, they now have signed a truce with the government. And those are things that are happening in our world that we never hear about. You never hear about unless you hear some little snippet, and then you dig and you start digging and finding out more information about what's going on.
These
So
are
really
important-
challenges in the world.
Well, these are important issues, but what I really want to see is Dan Sobel's face to see how time has changed it. So Dan, show us
Dan,
your
what's
face.
Dan, are you there? Can you, there you are. Wait a minute, you're on mute.
Unmute yourself, Dan.
Okay, I'm not muted and I'm not very pretty, so there's not much to say.
No, I think you're still beautiful.
Thank you, Eric. But I'm very impressed that Mike, who's been on, I saw him on a Zoom this morning for a couple of hours, and I see him around the table with you.
Well, Mike Kirchie is a
Kirchie.
member of our board of directors as well here at Partners for World Health, and very active down here. We love having him around.
It's actually just a hologram of Mike.
Ah. Oh, look at that. Someone pierced him in. You look good. Maybe we can talk sometime after this. I'll put my email in the chat for you, or Linda Brady, or anybody who might know me. I don't know.
hi, Dan.
Hi, Linda. Nice to see you.
Nice to see you.
Axel, do you have any questions or comments?
No, not at all a question, but it's very interesting. I have never been to Congo, although I'm from Burundi, which is on the west side of Congo. It's a small country, and if a lot of people know about it. I've known about Kinshasa as being one of big town, and the travels, like you mentioned about having like 6 people on a bike. You'd be surprised, it's very common, especially in the Central Africa.
Yeah.
And it's cheaper, so that's probably why they do it. And the traffic is horrible. So, and I was in Africa, in Rwanda actually, back in August, and it's much more, a little bit more developed than Congo or Ethiopia. Yeah, but it's you guys did a great job, and wish you great luck. And Partners World Health, like I'm currently working with Elizabeth, trying to see if we can get a container in Africa, Zambia, and as well in Burundi too.
That's right.
Yes.
It must be very challenging to get a container to Burundi, because that is quite a landlocked place.
It is. Well, we hope to get it, right, Elizabeth? You know.
Yeah, well, don't worry. Piece of cake. You know, there's one
Yes.
thing we do around here. It's 3 words: figure it out. And that's
True.
what, and the containers will go into Mombasa in many cases, or into Beira in Mozambique, if they're going to
Yes.
Zimbabwe or into Zambia, and then they go into those ports, and then they're trucked across. And we always encourage those that are supporting this effort to purchase the container, because there's a big safety issue with transporting a 40-foot container, and we only ship 40-foot containers from the US, and they eventually find their way to the final destination. In fact, one container I heard today is in Poland and it's being trucked into Ukraine tomorrow. And that's container number 5, I think it is, that we have shipped. And it'll land there and then it will be offloaded and the container will come back to the United States. So in most of the places in the world, the containers come back empty, unless you are shipping into India or into Bangladesh or other places in Southeast Asia where we bring products back to the United States, then they come back full, but most of the time they're coming back empty. Many places in Africa, they're all coming back empty.
So is it the same cost? to
It's
ship
the
back
same
empty?
cost. The cost of the container is from Portland, Maine, from Boston or New York to Portland, Maine, and then to the final destination, whether it comes back empty or not. If it's going to Bangladesh and India and other places where we import, it tends to be a little bit less because they're going to fill it on the other side and ship it back.
Bring any
Yeah.
residents or students to, eventually you're gonna get old enough, you can't do this. How do you,
Next week?
how do you supply a young population that might be interested in what you're doing?
We're struggling with that, Mike.
Great question.
We'd love to recruit younger people. For us, the sweet spot is people who are nearing retirement or just retired, but not worn out yet. But we know that I'll be worn out here in a few years. If my daughter's still on, she won't like hearing that. But yeah, we'd love to get residents to come.
Yeah, there's one's down there.
There's one.
She doesn't like hearing that.
So Ed, we have, in answer to part of your question to follow up, Mike, is that we are starting a relationship with the University of Massachusetts. And we've had a long relationship with them actually for 4 or 5 years collecting medical supplies. But most recently, the University of Massachusetts Medical Center has been in Zambia. And they are starting a program of sending residents to the university teaching hospital in Zambia in Lusaka, which is 1,500 bed teaching facility. And they're planning on having a residential program for non-invasive surgery and also infectious disease so that a resident can go for a month at a time or on a rotating basis. And the reason we ended up getting involved is because they needed medical supplies and they wanted a laparoscopic tower, et cetera. And they're trying to save this stuff from UMass. And it actually is something that we've been talking about here at Partners for World Health, is that how could we develop a relationship where hospitals, where university settings like UMass Medical Center, like Maine Medical Center, like University, like Tufts Medical School, Tufts Medical Center, that would help support the shipping of the container. And at the same time, we develop relationships where we can send doctors and nurses to provide education and training over there and let them have an incredible experience at the same time. So that's something we're just really looking into.
Yeah, because we were taking 2 residents a year in terms of the surgical program, the Maine Medical Center.
Right, in Rwanda, into Rwanda. Yeah.
Could you ship the residents and med students in containers?
No, of course we can't do that. Somebody would be on my back for that. I'd really get into trouble. Can't do that. But I don't want to leave out the nursing component of this, because you commented on how valuable the nurses are, because they are the ones that stick around. You know, those docs, there's a major brain drain that's going on in many of these countries where we have sent containers and where we do our medical mission work, that they come to the United States, they go to medical school, nursing school, and then they don't go home. So, you know, it's important that we need to bring our nurses over there and help to educate them too. We just came back from Bangladesh, and it was, we were there for 10 days at the National Institute for Cancer and Research Hospital, and we trained 84 nurses in a 3-day program, 2 3-day programs on safe administration of chemotherapy. And all of the 4 or 5 courses that they had to go through, and then clinical practice. And in this one particular hospital, they do 250 outpatient chemotherapy procedures within a 6-hour period at this hospital in Bangladesh. So we had great opportunity to teach them how to do it the right way. And when they pass the test and pass the certification with the certificate, very important certificate, They really felt good about themselves that, I'm doing this the way anyone does it here in this country. And that's important. I think it's important that we focus on docs, but we also focus on those nurses and provide that education and training. So I love what you're doing. So right up our alley. In fact, we do this Project 10,000 that we started in Uganda and Senegal, and we will do it in Kenya when we go to Kenya this time in May, which is
For
to,
your roots and iceberg too.
hi, Linda. Which is we gather data on interviewing pregnant women, and then we educate them on the complications of pregnancy, like the flip chart, because none of these women have any sorts of prenatal exposure. I mean, they just get pregnant and they wait, then they have a headache, they start bleeding, and nobody knows, or they're in labor for greater than 24 hours. And by the time they arrive and deliver the baby, you have a flaccid baby that dies or has cerebral palsy and all those complications. And one of the things that we talk about is to help us here in this country learn is that we have all the services available for children that are born with a disability. We have wheelchairs, we have crutches, we have education, and that's what they don't have in the developing world. And they need, so you want to be able to teach mothers how these complications so that they make sure they have a healthy baby.
Well, I
Big
think
issue.
the thing about teaching mothers is that mothers talk to each other and there's a great
Yes.
community among them. So when a mother learns something about a pregnancy, she will pass that on to her sisters, to her other, members of her community. Oh, your ankles are swollen. That's not good. You need to go see somebody. So I think in teaching one mother, you teach one mother, but you also spread that information to the whole community.
So we've educated over 2,500 pregnant women now since we started this program. And last time we were out in Uganda was January of 2020. And we were going back in this January, however, because of Ebola, which moved into Uganda and from South Sudan, we postponed that trip. So we're heading into Senegal instead. So it's working. So,
Yeah.
little things that are simple can change people's lives and keep people alive, keep mothers alive and keep babies alive. Because if that mother dies and there are 5 children at home, you have a
right.
whole social issue,
Mhm.
a social issue for the whole family and for the country.
Elizabeth, I'm going to take this moment to introduce myself, but I'm faculty at USM with our student nurses. I may be taking over Suzanne Parkman's partnership, so
Oh, well,
I'll be
nice to
talking to
meet you
you.
here. Yes, we have Suzanne Parkman here with her nursing students for the whole semester, and it's been a great experience. And I think that, I spoke to them a couple of weeks ago and we had a great discussion. And it's been wonderful having them down here. And Suzanne also traveled with us in March of this year to Bangladesh.
Oh,
When we went to the brothel in Tangai, we've been going there for 7 years now to provide primary healthcare services to the sex workers in a brothel, which is about 2,000 women and their children. And we're planning on going back there again in March. She did a research project actually there.
wow.
And it was published, yes. And she was nervous because she said, I don't think I'm going to get enough people to interview for my research project. And I said, don't worry, Suzanne, everybody is so excited to see us because we haven't been there for 2 years. And she had like 30 people, that
Wow.
answer all her questions. So I look forward to meeting you in person and working with you. This will be great. Great. Darius, how are you?
Oh, I'm fine, thank you.
So Darius, tell us yes?
Well, I want to commend the group for going to Zaire. And your presentation is really wonderful because I come from South Sudan, and I used to be a professor at the University of Vermont, and I had meeting with Elizabeth a long time ago before my stroke. I had a stroke, and I'm really happy to continue talking with you guys, and I started the program for maternity center in South Sudan, and we're working on it. And Elizabeth can tell me, I mean, she can talk more about it, you know, when you guys have time. But really, you know, with your support as well as for your presentations and so forth, it makes me really so happy, because I come close to Congo, and I wasn't. I mean, you know, I know the people very well. You know, even the area that you were talking about. Many years ago, I went to Kinshasa, as well as the eastern and the northwestern part of Congo. Really, it is wonderful for you guys to be doing these things, you know, because a lot of children and women are suffering, and I'm so happy. You guys are doing a wonderful job. And because I have a stroke, now I can talk a little bit, but sometimes I don't have words. And I'm doing my best so that I can catch up with you guys. And Elizabeth, wonderful job, really. I'm so happy for all your group, you know.
Actually, Darius, what they do in Congo, they should do in South Sudan and Mali.
That's what we're doing. Yeah, that's what we're trying to do. And we are right now working, doing appeals as well as contributions, so that we can put the maternity center would be
That's right.
function, you know. But it's wonderful. It's good to see you guys, and
Yeah.
to see and hear from you guys. It makes me happy, really, you know.
Can I ask you?
Even though, you know, I came from South Sudan and Congo, I live right now in Massachusetts, and I retired from University of Vermont. So it's really wonderful to hear you guys and to see your job, and it's all by volunteers, and you put a lot of what can I say, you know, since I have a stroke, you know, sometimes I don't speak well, but I really want to thank you guys all for what you're doing, you know, because it's not easy. Our people need all of us, you know, whether it is in Ethiopia or Somalia or South Sudan. We need your help, and we need people like you to do a little bit for all of us. Thanks for your help. Yeah.
Thank you, Darius. I think Eric has a question for you.
Yeah.
I like this question. Are there any Congolese music CDs behind you?
You said Congolese music or something?
Yes, he asked you if you had any Congolese music behind you on the shelves.
Oh, I have a lot. You see in the back?
We can.
You
we
see
can
that? You can see stuff on my back. You know, I
Yes.
have a lot of music over there.
Yes.
The Congolese say that they have the best music in Africa. What do you think?
Next time I will give it to you. I have a lot of music, but you know,
We have our relationship with South Sudan started in Vermont. With Cool. And he was one of the lost boys of South Sudan who came to the United States when he was about 10. And he
Yeah.
ended up in Vermont, and now he's the director of admissions for the University of Vermont. And
That's right.
his efforts and many of the lost boys that live here in the United States, they have raised money to ship 2 containers to Bor and another container that's on its way to Magui, and then another container that we have going at some point.
Yeah.
So 4 containers from here are going to end up in South Sudan. And we visited there. I went there in December of 2019 for Christmas. It was incredible. Incredible country that has survived famine and droughts and flooding and wars. And they're standing up tall, and they're going to be a major player in the world. So I'm so glad you were able to join us tonight, Darius.
Thank you so much. Yeah. And thank you all, really, for your presentation as your work.
You're welcome. Any other comments or stories to share? Well, it would be the end of the evening, and in the Saudi basket, we have to pick a name out for the prizes that are down there at the end, right next to you, Anne.
Okay.
So the first one is Mexican music, a tape of Mexican music.
Me?
Yes, you can pick.
Vanna, right. Oops.
I don't need Spanish, so I can.
Spanish
kind of
music,
folk
I'd probably say. Irwin Webb. I don't think he's here.
¿Dónde está?
Oh,
¿Dónde está? No,
no. Irwin Webb.
not so.
Nope, not here. Next pick. You have to be here. Axel. Axel.
Perfect.
So we'll put your name
Wow.
on it.
Yeah.
We'll put your name on it, and you can pick it up in the volunteer office, okay?
Will do. Thank you very much. Will do that.
We can ship it to Zambia.
That works too.
And the next one is a photograph from one of our volunteers, from Christine. Did you?
Linda Brady.
Linda Brady.
Which one does she like?
Whoa.
Linda, you are the winner.
Of what? Chicken dinner?
Of
The,
what?
of the picture.
This one has the ocean.
Yes,
Select
Anne
which
has
one.
picked you.
And pick the one for me.
I did.
Oh,
You
yes.
like that one.
Okay, thank you.
So Linda, you'll have to come into the office to pick it up.
Oh,
And
Jesus.
that means I'll get to see you again. It's been so many years. I'm looking.
I know. I will. I'll have to find out where you are again.
We'll email you.
We'll email you.
Okay, perfect.
more.
Thank you.
Another picture by Christine, one of our volunteers.
It's for Sally Thompson, who was here most of the time.
She was, so we'll give it to Sally.
Sally
Yeah, we'll
Thompson,
give it to Sally. She just checked off.
Yeah.
Okay, well, thank you very much for joining us this evening.
Thank you, everybody.
And
Thank you.
yes, and don't forget about the craft fair on December 3rd. I just want to put another plug in for that. And we also, I forgot to mention, but on International Women's Day is March 8th. And Partners for World Health will be doing something on International Women's Day to focus in on women empowerment throughout the world. So stay tuned. There'll be more information on the website and through email blasts and Facebook. You know, how could we do anything without Facebook? Any other questions or comments? And we want to thank our speakers here this evening for coming, and we have a little surprise thank you present for each of you. And this is a little something from Peru for you.
Oh,
And
thank
this is a
you.
bowl made by our biomedical technician.
Oh, that's fantastic.
Wow,
So-
thank you very much.
You're very welcome.
Yeah.
Uh,
So thank you very much for joining us. And we look forward to seeing you down here Hey, Dick, I see you have your blue button on.
Yeah,
Yes,
absolutely.
that's right. BBC,
Yeah.
the blue button for commitment.
It's important.
That's right, it is important. Thank you very much for wearing that.
My pleasure.
Okay, good night, everyone.
All right,
Thank
good
you.
night. This was
Good
great. I
night.
loved it.
Okay.